Good afternoon, guys. Today we have a lecture chest trauma. Epidemiology. The fact that is has become possible in recent decades for millions of people to travel at high speed had led to a phenomenal increase in blunt injury to the chest, the most lethal type of injury. All casualties, and particularly children who have been exposed to blunt chest injury may have sustained highly lethal internal lesions, rupture of the heart, the aorta or a minor airway, for example, or a contusion of the heart although the external stigmata of chest injury may be quite trivial or even absent altogether. For this reason, any casualty who has sustained blunt trauma to the chest should be considered seriously injured until proved otherwise. Frequency of various injuries in motor vehicle accident. Extremities 34%, head and neck 32%, chest 25%, and abdomen 15%. Mechanism of injury in chest trauma. It's acceleration or deceleration motor vehicle accident. Body compression, crash injury, high speed impact gunstone wound, and mescelinose. It's low velocity penetration, stab wound, airway obstruction, suffocation, caustic injury poisoning, burns, and electrocution. On this picture you can see a schematic diagram of the various forms of thoracic injuries, showing how disturbed cardiopulmonary physiologic equilibrium results in tissue anoxia or acidosis. Trauma death. In 50% it's immediate death, within seconds or minutes, due to spinal cord injuries, severe brain injuries, lesions to great vessels. Prevention is optimum pre-hospital care. Early death from 30% to 35%. Within hours, it's golden hour. Due to thoracic trauma, liver and spleen or spleen injuries and bleeding, multiple pelvic fracture and others. Prevents its optimum initial care. And late death from 50% to 20% within 2-3 weeks due to sepsis, multiple organ failure, prevent optimum initial care. Percentage of specific types of thoracic organ injuries. It's chest wall, 54%, flail chest, 13%, pneumothorax, 20%, hemothorax, 21%, pulmonary, 21%, and miscellaneous, 18%. Assessment of patient with thoracic injuries. The evolution of thoracic injuries is only one aspect of the total assessment of severe injury patients. Both diagnosis and therapy go hand in hand. The basic principle of elective surgery: first investigate and make the diagnosis, then treat the illness, is a dangerous illusion. The first step is to make a raw estimate of the status of the circulatory and respiratory systems. This provides the first diagnostic clues and often determines which therapeutic action is to be taken. Specific questions are then posed pertaining to individual injuries or their consequences. Monitoring and evaluating the patient with thoracic trauma. The first, rentgenograms of the thorax, chest wall, its ribs, sternum, vertebral, and clavicles. Mediastinum, white or normal, shift or not, lung, parenchyma, contusion. The heart may be cardiac tamponade, diaphragm may be rupture of diaphragm, and pneumothorax or hemothorax. Next examination, electrocardiogram, central venous pressure, excuse me, arterial blood gases, urine output, laboratory investigation, and others. Management of patient with thoracic trauma. The treatment of polytraumatized patient must follow a certain protocol which includes adequate oxygenation, fluid replacement, surgical intervention, treatment of septic complications, adequate caloric and substrate supplementation, prevention of stress bleeding, and finally be alert of possible complication from CNS, RDC, hepatic, renal, coagulation disorders, and sepsis. On this picture you can see mechanism of injury, rib and sternal fracture. On this picture you can see indirect violence. Next picture, direct violence, maybe with lung injury are more common. Rib and sternal fractures. Diagnosis. Patients complains of localized pain that is aggravated by coughing or a deep breathing. Localized tenderness. Subcutaneous emphysema. False motion, paradoxical respiration. Rib fracture must be diagnosed clinically. Many rib fractures are not visible on X-ray tests. On this picture you can see a flailed chest. It's a two-side fracture of the rib with forward window. On this picture you can see mechanism of paradoxical respiration. Mechanism of paradoxical respiration. Therapy in multiple rib fracture. Not taking companion injuries into consideration. If patient has stable thoracic wall, we must do controlling pain or intensive breathing exercise. If patient has unstable thoracic wall with paradoxical respiration, we must do analgesics, morphine derivatives every 4 hours, even if there are no pains. If necessary, intercostal nerve block. If necessary, epidural anesthesia. Only in cases of respiratory insufficiency, we must do mechanical ventilation, prophylactic insertion of a chest tube. In exceptional cases, operative stabilization of the thoracic wall. On this picture you can see points for intercostal blocks. It is a tried and tested rule that a prophylactic chest tube should be inserted in every patient with multiple rib fracture who is to undergo an operation under general anesthesia, even when there is neither evidence of a hemothorax nor of a pneumothorax. Pneumothorax and hemothorax. Cases of pneumothorax and hemothorax can be provided with extremely effective therapy for the most part with simple methods. In more than 80% of cases, it must, however, be given early. Furthermore, the drainage of air and blood must be efficient. Tangent pneumothorax, life-threatening. Every traumatic pneumothorax can develop into tangent pneumothorax. However, this complication is rare with spontaneous breathing. Very frequently, in a more dangerous form, by far a tangent pneumothorax occurs during mechanical ventilation. Treatment consists of immediate relief of pressure. Open pneumothorax. Diagnosis: a penetrating thoracic wound with a sucking sound of incoming and outgoing air. Sucking wound adds to the clinical and radiological evidence of pneumothorax. Therapy: immediate air tight closure of the thoracic wound, immediate intubation and mechanical ventilation. Hemothorax. Diagnosis: its diminished breath sound, muffled sound on percussion, X-ray chest examination, clothing over the affected half of the thorax up to complete opacity. In the diagnosis of hemothorax, formation of atelectasis and rupture of the diaphragm should be differentiated. Sources of blood accumulating in the chest following blunt or penetrating trauma, pulmonary parenchymal laceration, rupture of pleural adhesions, mediastinal injury with or without vascular injury, cardiac injury with pericardio-pleural communications, decompression of abdominal hemorrhage through a traumatic diaphragmatic injury. Therapy. The key to successful management of acute hemothorax is early, aggressive care in the form of adequate pleural evacuation by thoracostomy or thoracotomy in order to minimize the morbidity. The rate and cessation of bleeding depends on the site and size of the bleeding wound. Thoracotomy is done if the bleeding is constant and more than 300 milliliters per hour during the first 3 to 4 hours. However, tube thoracotomy is all what is needed if bleeding is less and decreasing without radiological evidence of clotted blood. Insertion of chest tube. On this picture you can see steps for pleural drainage. Incision our intercostal space. Next step, development of subcutaneous tract. Next step, penetration of parietal pleura with clamp. And next step, confirmation that lung is not adherent to chest wall at puncture site with finger. On this picture you can see two-type drainage of pleural cavity. First type is single water seal, it's allow drainage. And second type is double water seal, it's active aspiration drainage of pleural cavity. On this picture you can see pneumothorax. We see atelectasis of the lung. We see concourse of gas in pleural cavity and shift of mediastinum to the health part, health site. On this picture, you can see hydrothorax or hematothorax with concourse of fluid, accumulation of fluid or blood in the pleural cavity, right pleural cavity with level of the fluid. Lung parenchymal injuries, maybe lung laceration or lung rupture. Clinical significant, mostly harmless, exception, central lung rupture. Therapy, conservative thoracic drainage in pneumothorax and hemothorax. Operation only in exceptional cases because of bleeding or massive hair loss. Excuse me. Intrapulmonary hematoma, clinical significant, unless therapy is known. Excuse me. Traumatic lung pseudocyst, clinical significant, harmless, therapy mostly known. Simple lung contusion, clinical significant, mostly harmless, can develop into lung contusion with respiratory insufficiency. Therapy, breathing exercise, careful monitoring of progress. Lung contusion with respiratory insufficiency. Clinical significant, progressive respiratory insufficiency. Maybe hypoxia, right to left shunt, interstitial edema, considerable mortality. Excuse me. Therapy, intubation and positive and expiratory pressure ventilation. Maintenance of a normal oncotic pressure. Fluid infusion, limited human albumin, 29%. Steroids. Blast injury, clinical significant. Severest injury, progressive respiratory insufficiency, danger of arterial air embolism, hematothorax, pneumothorax, and abdominal injuries. Therapy, as in lung contusion with respiratory insufficiency. Abnormalities following bronchial rupture and methods of management. Immediate it's acute respiratory insufficiency. We must do intubation and emergency repair. If acute infection, it's mediastinitis or empyema or early bronchial obstruction with atelectasis, we must do emergency repair or resection of the lung. Delayed bronchial rupture, pulmonary infection, pneumonia or abscess. Outcomes may be fibrosis, and delayed bronchial obstruction may be formed bronchoectasis. We must do elective pulmonary resection, may be formed pneumonitis and atelectasis. Pneumonitis outcomes fibrosis or abscess. If abscess, we must do pulmonary operation, resection or drainage this abscess. On this picture, you can see pathologic course following esophageal perforation. Essential components of an procedure used in management of esophageal perforation. Therapy, non-operative. Fluid and electrolytes infused. Antibiotics, high dose and topical or lumen. Prevent further contamination with gastric tube or drainage. And plus operative. Drainage of mediastinal and facial planes. Maybe resection only resection, maybe resection with reconstruction. Excuse me. Diaphragmatic injury of the diaphragm, diaphragmatic rupture. Incidence in 3% of all severe thoracic injuries. Mechanism: broad surface blow. Location: left side in 85% of cases. Clinical picture: acute. Symptoms of companion injury and shock. Chronic intestinal obstruction or strangulation usually. Examination, radiological examination. Rupture of diaphragm are frequently overlooked. Therapy is indicated for increasing impairment to respiration. Operative approach from chest or abdomen. On this picture you can see stomach in left pleural cavity, stomach with level of fluid, uh, and we see a shift of mediastinum to the right side. On this picture you can see stomach in pleural cavity and gastric tube in the stomach and level of fluid. It's traumatic diaphragmatic rupture. Traumatic emphysema may be subcutaneous emphysema or mediastinal emphysema, present in about 27% of patients with blunt or penetrating chest injury. Therapy. Despite its impressive appearance, the treatment of subcutaneous emphysema itself is mostly unnecessary. Determine the site of origin. Treat underlying pneumothorax if present by tube thoracostomy. Treat tracheobronchial or esophageal rupture or tangent pneumothorax in case of mediastinal emphysema. Rarely, cervical mediastinotomy is needed for mediastinal emphysema. Non-penetrating wounds of heart. Cardiovascular injuries. Myocardial contusion occurs in 76% of patients with severe blunt chest trauma. Right atrium and ventricle is commonly injured. Injury may reduce strength of cardiac contractions, reduce cardiac output. Excuse me. Electrical disturbance due to irritability of damaged myocardial cells. Progressive problems due to hematoma, hemopericardium, myocardial necrosis, dysrhythmias, heart failure, and or a cardiogenic shock. Myocardial contusion signs and symptoms: bruising of chest wall, tachycardia and or irregular rhythm, retrosternal pain similar to myocardium infarction, associated injury, rib or sternal fracture, chest pain unrelieved by oxygen, may be relieved with rest. This is trauma-related pain, similar signs and symptoms of medical chest pain. Pericardial tamponade. Its restriction to cardiac filling caused by blood or other fluid within the pericardium occurs in less than 2% of all serious chest trauma. However, very high mortality results from tear in the coronary artery or penetration of myocardium. Blood seeps into pericardium and is unable unable to escape. 200, 300 milliliters of blood can restrict effectiveness of cardiac contractions. Removing as little as 20 milliliters can provide relief. On this picture you can see subxiphidal puncture of pericardium for evacuation of blood from pericardium. Next signs and symptom pericardial tamponade. It's dyspnea possible, cyanosis, Beck's triad, jugular vein dilatation, distant heart tones, hypertension or narrowing pulse pressure, weak and thready pulse, shock. Kussmaul signs its decrease or absence of jugular vein dilatation during inspiration. Pulse paradoxus, drop in systolic blood pressure more than during inspiration due to increase in uh, carboxy dioxide during inspiration, electrical alternations, PQRS and T amplitude change in every other cardiac cycle, and PA. Myocardial aneurysm or rupture. Myocardial aneurysm maybe occurs almost exclusively with extreme blunt thoracic trauma, secondary due to necrosis resulting from myocardium infarction. Signs and symptoms: severe rib or sternal fracture, possible signs and symptoms of cardiac tamponade if affects valves only, signs and symptoms of right or left heart failure, and absence of vital signs. Traumatic aneurysm or aortic rupture. Aorta most commonly injured in severe blunt or penetrating trauma. 85–95% mortality. Typically, patients will survive the initial injury insult. 30% mortality in 6 hours, 50% mortality in 24 hours, and 70% mortality in 1 week. Injury may be confined to areas of aorta attachment. Signs and symptoms: rapid and deterioration of vitals, pulse deficit between right and left upper or lower extremities. Pathophysiology of thoracic trauma, cardiovascular injuries, other vascular injuries, rupture or laceration, may be superior vena cava, inferior vena cava, or a general thoracic vasculature. Blood localizing in mediastinum, compression of great vessels, myocardium, and esophagus. General signs and symptoms: penetrating trauma, hypovolemia and shock, pneumothorax, or hemomediastinum. On this scheme, you can see algorithm for diagnosis and management of penetrating cardiac injuries. Uh, penetrating cardiac injuries therapy, arterial repair. After approach to the heart, we must do next step. We finger pressure wound of atrium, after this clamp, and after this suture this wound. Same aorta repair. We closed with finger pressure of wound of aorta, after this clamp, and after this suture of this wound. And same ventricular repair. We closed with finger wound, finger pressure, and after this suture this wound. On this scheme, you can see repair postoperative period after cardiac injury. Other injury patterns in thoracic trauma. 1. Traumatic asphyxia. Due to a severe compression of thorax with sudden increase of pressure in the venous system, resulting in a characteristic injury pattern, where small hemorrhage in the conjunctiva, the skin and the mucous membranes of the throat and head, and reddish blue discoloration in the later region. Therapy is for the complication injuries, is for the companion injuries and cerebral edema if present. 2. Injuries of the thoracic duct, helothorax. 3. Holothorax due to rupture of diaphragm and damage of liver and concourse of bile in the pleural cavity. 4. Traumatic induced hernia of the chest wall. 5. Arterial air embolism. And 6. Blast injury. Indication for thoracotomy. Decision to operate, excluding minor surgical procedures such as tracheostomy, pericardiocentesis, tube thoracostomy, and suture of chest wall lacerations. Formal operations are required in only 12 to 15% of patients with thoracic trauma. Indication for thoracotomy: acute post-traumatic cardiovascular collapse, pericardial tamponade, vascular injury to the thoracic outlet, traumatic thoracotomy, massive air leak, proved tracheobronchial injury, proved esophageal injury, great vessels injury, continuing hemothorax, mediastinal traversing injury, ballet embolism, air embolism. Indication for thoracotomy: chronic, unevaluated clotted hemothorax, chronic traumatic diaphragmatic hernia, chronic cardiac septal or valvular lesions, chronic false aneurysm, chronic non-closing thoracic duct fistula, infected intrapulmonary hematoma, missed tracheobronchial injury, and traumatic arteriovenous fistula. Initial assessment of the most important thoracic injury. Tension pneumothorax may be inflated hemothorax with reduced mobility of thorax, hypersonorous auscultation, weakened breath sound, venous congestion, increasing evolution of central venous pressure. Additional examination is known and treatment: immediate pleural puncture with drainage or aspiration. Open pneumothorax may be thoracic wound with sound of air rushing in and out, sucking wound. Additional examination is known and treatment: tight bandage plus ICT or intubation and mechanical ventilation. Cardiac tamponade may be location of wound in the pericardium or a corresponding tract of the bullet or knife. Additional examination is known. Treatment: pericardiocentesis or operation. Rib fracture may be local tenderness, compression pain, possibly repetition on auscultation, inspection, possibly paradoxical respiration. Additional examination, chest rentgenogram. Treatment, relief of pain, intubation and mechanical ventilation when respiratory insufficiency occurs. Pneumothorax, hyperresonance, uh, diminished breath sounds. In additional examination, maybe chest rentgenogram. Treatment, thoracic drainage. Hemathorax, dullness, the percussion. Chest rentgenogram and treatment, thoracic drainage or operation. Subcutaneous emphysema, maybe subcutaneous crepitation. Additional examination, chest rentgenogram, and treatment depends on the reasons. Rupture of bronchus, maybe mediastinal emphysema, pneumothorax or retention pneumothorax, no expansion of lung during thoracic drainage, and total atelectasis. Uh, Additional examination, bronchoscopy or X-ray examination. Treatment, operation. Rupture of esophagus, maybe mediastinal emphysema. Additional examination as esophagography. Treatment, operation. Mediastinal emphysema, characteristic crunching sound above the heart, synchronous with the heartbeat. Hammond's signs. Additional examination, chest rentgenogram, central venous pressure investigation. Determination of possible cause by means of bronchoscopy or esophagography. Treatment, cervical mediastinotomy only when there is significant venous congestion and no rupture of bronchus or esophagus. Diaphragmatic rupture, maybe due to percussion, dampened or hypersonorous percussion. Additional examination, rentgenogram or of thorax with possible use of nasogastric tube and or contrast media. Treatment, operation. Rupture of aorta, maybe possibly pseudocarotation syndrome, possibly compression syndrome in the upper mediastinum, possibly systolic murmur, on rentgenogram, white mediastinum, tracheal displacement to the right, displacement of the left bronchus downward, possible left-sided hemathorax. Additional examination, its aortography, treatment on the operation. Cardiac contusion, maybe on electrocardiogram, irregularities in repolarization, disturbance in rhythm and conduction, infarct patterns. Additional examination, cardiac enzymes and electrocardiography. Initial therapeutic measure, electrocardiography monitoring and drug treatment of rhythm irregularities and of possible cardiac insufficiency. Thank you for attention, guys. We finished our lecture.